All right. Hello, everyone, and welcome to the Pharmacy Community College Connect webinar. We are so excited for you all to join us. I am Madison Jeffrey, and I'm the Assistant Program Manager for PC3.
And I'm Regina McClinton. I'm the Assistant Dean for Diversity, Equity, and Inclusion here in the College of Pharmacy at the University of Michigan. And we are so thrilled to have you. We're so glad that you're interested in the Pharmacy Community College Connect program. So let me give you a brief introduction to health equity. Health equity is when all people have the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstance. So let's take an example. Let's say that I have a chronic disease and I am also unable to work full-time. Your full health equity may be different than my full health equity because of my chronic disease. But each of us should be able to attain whatever that full amount is and not be disadvantaged. So I should not be prevented or encounter a bunch of barriers in achieving my full health equity just because I'm unable to work full time. And we'll see in a bit the association between work and health insurance. All right. So that is health equity. And in the next slide, right, does everyone have health equity? The answer is no, right? And so if you remember, we said any other determined factors, some of the factors that prevent some people from achieving their health equity are socially determined. And so social determinants of health, or SDOH, are social factors apart from the actual medical care that are involved in shaping health across a wide range of indicators, settings, and populations. So if we think about this, you, let's say, have diabetes and you start working with your doctor, and your doctor creates a plan of healthcare for you. Okay, so that's that medical care component. But outside of that are many other components that affect your ability to achieve your full health equity. And many of those come from factors created and maintained by society. So let's go ahead and take a look further. All right, some of these social determinants of health include one's income, educational inequalities, employment status, language barriers, unequal access to health care, limited access to transportation and healthy food, limited housing options, environmental conditions, and more. So we want to look at this in more detail and connect some dots for you. This is what we I call the river of social determinants of health, okay? And it goes to an allegory where two people are sitting there by a river enjoying a nice meal, and they see a child floating in the river. So they jump up and they jump in and they rescue the child. As soon as they get the first child out, they see another child coming. So they go back in and they're rescuing that one. And then they see more and more children coming. One person stays at the river, but the other person takes off towards the start of the river. And the person who stays at the river says, "Where are you going?" And the person who takes off says, "I'm going to find out what is putting these children into the river." And so if we think of social determinants of health as a river, what we can see is that people are tossed into it at various stages of their life, and these can have, therefore, long-term consequences. So, for example, if we start here in the middle, right, under living conditions, we see physical environment, right, transportation, housing, incarceration, parks and green spaces, and we also see social environment, experience of prejudice and inclusion, or isolation, I'm sorry, immigration, culture, such as ads and media, right? Those are things that begin to affect you later in life, like in your teenage years or even later. But if we go to the very start of this river, the social inequalities of race, class, gender, sexual orientation, and ability will throw you into that river at birth. Okay. And so if you are tossed into that river that early, you then encounter the institutional inequities, including investments, right? Where the country puts its funding, wealth, how it's distributed, and power, how it is distributed, right? We have enough to go around, but it is not distributed equally. And so they serve to reinforce those social inequities that toss you in at the start. So something like race, the reason you kind of hear people have such outcry about race so much is because it tosses you into the river at the start, and it almost makes it impossible to get out of the river. And we'll take a look at that in a few moments. But as you can see, further down, risk behaviors, right? And so if race is not throwing you into the river early, right? If your gender is not throwing you into the river early, if you live in a nice area and you start to take on risk behaviors, then like tobacco use or drinking a lot of alcohol or illicit drug use, then those can throw you into the river as well. But it may be easier to get out of the river if those are the only components tossing you in, because they are not being reinforced by the institutional inequities. If though you are a Black trans woman, okay, we hit several of those, a poor Black trans woman, right? The institutional inequities toss you in early, work to keep you there, and then you take on tobacco use, it just makes it even harder to get out of this river of social determinants of health. Let's go on to our next slide. And so this just reinforces again that the social inequities are being determined by and reinforced by the institutional inequities that exist in this country. So I want to step through an example with you. One of the determinants of health, socially defined, is one's education attainment. And so the amount of education you gain determines many things, and one of those is work. The kind of work you get to do because of the education you gained determines several other things, including your working conditions, your work-related resources, and income. So when we think about working conditions, are you being exposed to hazards on a regular basis, right? If you have to work a blue-collar job, hourly hourly rate, then you may have to have a job that exposes you to hazards. You may get a job you think won't expose you to hazards, such as being a bus driver, great career. But as we saw in COVID, especially here in the Southeast Michigan area, when the pandemic hit, many people that were essentially service providers, right? Housekeeping workers in a hospital, bus drivers, still had to go to work. And if they got sick with COVID, they kept going to work because they were afraid they would lose their job. And so bus drivers were becoming exposed to COVID because they still had to transport workers who themselves were sick, but were not getting any treatment or isolating, right? And so whereas for me, working at a university, I stayed home, right? We were told, do not come in, but here's your laptop. And if we need to get you some internet speed increase, we will support you in that, et cetera, right? That job supported me in surviving COVID in a very healthy way. But for some people, it was a very risky situation. Control demand imbalance, right? Do you get to control your hours, your schedule, and the amount of stress associated with that and the kind of stress that goes with your job? Work-related resources such as health insurance. So if you have a job, maybe it even works 40 hours, gives you 40 hours a week of salary. If they do not provide health care for you, then you're trying to navigate these waters without health care. There is the Affordable Care Act, and that has definitely supported many people in this country, but it's still not the same as the kind of healthcare you get if your company can provide a really solid healthcare plan for you. Do you get sick leave? Not every job provides that, or retirement benefits, right? And then income. The amount of income you get is determined by the kind of job you can get, which is determined by education attainment. And that determines housing, right? What kind of house you can afford. Are you living in public housing? Are you renting? The neighborhood environment you live in. What kind of nutrition are you able to access? Because if you have to live where there is a food desert, right, you're probably going to get a lot of fast food, junk food, no real nutritional value. And the stress of living paycheck to paycheck or worse, trying to, pay one bill, paying one bill for three bills, providing for your children, right? Your children say things like, oh, mom, can I have $10 for, the after school event? And you have to decide, do I give them that $10 and where does that come from? Because I don't have extra. Or do I have to tell my child no and make them aware of the challenges of what our income level is? That's heartbreaking for parents. I've seen parents go into massive amounts of debt because they did not want to have to tell their children that they just didn't have the money on hand. Now, we've talked about educational attainment and how does that get socially determined? Well, what we know in this country is that where you were born by your zip code, we can pretty much determine your lifespan, because where most people are born is where they stay. And if you live in an area where the educational system is not a very strong one, then even though you may graduate high school, what you've come to understand or know or been taught may not be sufficient enough. You might try college and it might not work out. You might go to college and realize there was a whole lot they didn't teach me. And so education attainment is a socially determined factor in determining one's health. Let's go on to the next slide. Right, so now when these social determinants negatively affect health equity, the results are what we call health disparities, right? An absence of parity among people. And the next slide, we define health disparities. They are a particular type of health difference that is closely linked with economic, social, or environmental disadvantage. And so what does that mean? Let's say the rate of coming down with cancer due to environmental factors, okay? You live in a really nice neighborhood, very clean, lots of green spaces, no factories or anything nearby. You have a lower risk of coming down with cancer due to environmental factors. Let's say you live next to a factory. They don't care about how they are getting rid of their waste, right? They don't cap their emissions so that toxins are not in the environment. And you lived there for 10 years. You had exposure to toxic chemicals, and your risk for coming down with cancer is much higher than the previous person. That is an absence of parity around risk of coming down with cancer. So it's not innate. It's not like, you have genetic predisposition. It's just based on this kind of exposure or lack of resources that create these differences. So these are preventable, right? If that company had done better with, regulating their emissions, keeping their toxic chemicals under control, proper disposal, you could have the same risk of coming down with cancer as somebody who didn't live near a factory. So they are preventable. They are health differences between groups of people, and the differences can affect how frequently, right, a disease affects that group, how many people get sick, or how often the disease causes death. In our next slide, we want to bring all of this together, right? So there are three components of health: the social determinants of health, health equity, and health disparities. And health equity is the goal of health, that each of us accomplishes 100% of our health equity. Even though mine may not be the same as yours, I hit my 100, you hit your 100. When health inequities exist, we see them as those health disparities, right? The differences among different groups of people. The social determinants of health are these societal factors by which those differences come to exist, okay? So I can't meet my full 100%. That's a health disparity. Why can't I reach my full 100%? That's determined socially by these social factors that we've been discussing. Next slide. So how do we address health disparities? Well, research shows, I love the phrase, research shows that an effective way to address health disparities is to diversify the healthcare workforce. Well, what does that matter? What we understand is that patients respond better when their healthcare provider understands their cultural, spiritual, mental, and emotional needs. And this occurs most often when they are working with a provider who is similar to them in these categories. So by increasing representation in the healthcare workforce, patients will have better health outcomes. This was another thing we saw with COVID, right? That many people, many African Americans in the Detroit area did not trust their doctors. They did not have doctors that looked like them. So when these people are saying you need to get this vaccine, you have people like, 60, 70 years old that have seen vaccines be developed, never like this. Never, never, ever this fast. And the government's like, oh, you got to get it. Trust us. Yeah, we've trusted you before. That didn't exactly work out so well, right? They were hesitant, if not completely reluctant, to get the vaccine. But if they had a doctor that, say, maybe lived in their neighborhood or went to their church, someone that they knew, someone that ate at the restaurants that they like to eat at, etc., right? Had seen some of the same movies and they could chat about them in the doctor visits. Then they might have been much more willing to accept the advice and recommendation of their doctor to get vaccinated, and then to be able to say, I'm not comfortable because this thing came on real quick. Are you sure? Right? If you're saying that to another doctor, I'm a woman of color. I have a PhD, doggone it. And I have been dismissed by doctors. I put them in check, but it has happened. So imagine you're now there with your white doctor. You're like, well, doc, I don't know about this vaccine. Oh, just trust me. That's not what needs to happen in that conversation, right? Why are you hesitant? What can we discuss? What can I share with you that will help you feel more comfortable taking that vaccine? And I'm not saying that white doctors don't do it, but they're less attuned to doing it with patients of color because of assumptions that they make, like they're not that well educated. Imagine the shock when I say, just so we're clear, it's Dr. McClinton. Next slide. So we want to share with you this brief video, and we'll chat just a bit and keep going from there. Madison, it's yours.
Communities of color are disproportionately underrepresented in the health workforce. That trend won't change unless we prioritize the problem now. How do we achieve health workforce equity? We start with getting on the same page about the scale of the problem. We gathered data on people currently working in or training in 10 healthcare professions. Compared to the overall health workforce, Black healthcare workers were underrepresented by an average 46% across professions and in all of the 10 professions that we looked at. Additionally, in 5 of 10 professions, the representation of Black graduates in the pipeline is lower than in the current workforce. Hispanic healthcare workers were underrepresented by 76% and in 10 out of 10 professions. Native American people are underrepresented by 46% in the health workforce and in 9 out of 10 of the health professions, with Native American graduates underrepresented by 43%. Even with slight improvements in the pipeline for Native American and Hispanic graduates, representation in our healthcare workforce isn't where it needs to be. So how do we start moving in the right direction?
It's really about access, and it's about access early on for generations, quite frankly. Black, Hispanic, and Native American students haven't had the same level of opportunity. But what we have seen is that when institutions and policies create access, those opportunities are maximized by students of color.
I myself am a product and testimony that these programs work. And I'm a believer that you have to, share the wealth, right? You have to pay it forward. We have lost, hundreds of thousands of people in the US to COVID-19, and disproportionately, most of the affected ones have been racial and ethnic minorities. Racial and ethnic minorities receive less access and less quality of care services when we don't have a diverse health workforce.
Awesome. Thank you, Madison. So you may be asking, what do they mean by all these percentages? What they're saying is this. If you take the proportion of different racial and ethnic groups in the United States, and whatever that is, let's say for African Americans, we represent 11% of the United States population. If you then look at the healthcare workforce, the percentage of African Americans in the healthcare workforce is not 11%. It's a lot less. And so that is what they mean when they say this group is underrepresented by, let's say, 43%, right? Whatever, 43% of 11% of that number is how many people that could be in the healthcare workforce that are not in the healthcare workforce. So to support the understanding of the need to diversify the healthcare workforce, this group has created a tracker to identify that. And you can see on this wonderful graphic here, they've got physical therapists, dentists, nurses, speech pathologists, respiratory pathologists, and of course the pill bottle with some pills outside representing pharmacy. But as you know, we do more than just identify medication. Let's go on to the next. All right. So again, what does this have to do with being a pharmacist? Pharmacists are actually the most accessible healthcare provider across the country. You can literally walk into any community pharmacy and ask the pharmacist a question. Today, I went and picked up a prescription for my sister who was sick. She has like a big PPO that she works for. And they gave the medication, and I had her call in on the phone and speak with the pharmacist. They said, would you like to speak with the pharmacist about this medication? Yes, we would, because it was a new medication. And the pharmacist had this wonderful conversation with my sister, right? Even in this healthcare system, they are accessible and free. And so because people tend to get all of their medications at the same pharmacy, be it through their hospital system or community pharmacy, they build a relationship with the pharmacist, and this can support them in meeting their health and medical goals. So what do pharmacists do? It's exciting. Here we go, right? So you have the clinical pharmacists that work in hospitals and clinics right alongside physicians, and they aid in patient assessment and figuring out what medications to prescribe based on the patient's needs and unique situations. Then we have community pharmacists who you may likely be most familiar with, and they work in retail pharmacies to dispense medications and to also counsel patients about safe medication use. Next, we have industry pharmacists. Yes, industry, right? And they work in the biotech and pharmaceutical industries through drug discovery and educating healthcare professionals about the latest therapies. Next is information technology. Maybe you're really cool and big on computer sciences. You can combine that with a love of pharmacy, right? And so pharmacists combine the use of technology with drug treatment to help physicians and hospitals communicate with patients and to manage their treatments. And so you can be like my colleague, Mike Dorsch, who you're welcome to look up on the College of Pharmacy website. And he combined his love of healthcare and pharmacy with his love of coding. And so he and colleagues created an app that understands where you are. And let's say, you're standing in front of a Wendy's, not that I've done that anytime soon. And it senses that you're there and says, hi, Regina, I understand that you're near a Wendy's. These are the items that are allowed on your diet for you to eat. Because if I'm managing my salt intake, it knows the Wendy's menu better than I do. and says, nope, nope, nope. Okay, she could have the salad. Nope, nope. She could have this. She could have that, and makes those recommendations. And they've seen this to be wonderfully effective in helping patients control their salt intake. Regulatory and federal positions for pharmacists. They work in a variety of governmental agencies. Maybe it's at the county level or all the way up to the FDA, Food and Drug Administration. Vital roles include making sure drugs meet the requirements to go to market. They conduct research, delivering healthcare to vulnerable populations, and more. And then research pharmacists. These folks take new drugs and therapies through the clinical trials, right? And make recommendations for the physicians regarding disease treatment. Then there are two new areas, or relatively new areas, about pharmacy work that I'm happy to share with you today. One of those is what we call precision pharmacotherapy, okay? And that's where pharmacists work to identify the right drug for the right dose, for the right duration, and for the right patient. Because one of the things we've learned is that essentially our protein makeup, right? Okay, so biology majors or folks who've had biology, right? Your genes, your DNA broken down into these segments called genes, right? Your genes encode proteins, and it's really your proteins that kind of drive the show, right? We can all have a same protein, but it might be flavored a little bit, right? Just like eye color. Each of us has an eye color, but the actual color of our eyes is different, right? And so some of those differences in our proteins determine how effective a medication will be in our bodies. So by understanding the genetics part of it and the pharmacy part of it and bringing all of that together helps us to now treat patients at like this Uber level, I like to think of it, right? And so we use all of the patient, their genomics, their metabolomics, their metabolism, right? Proteomics, those proteins, organ function estimation. Maybe, your liver isn't functioning at a high enough rate for a particular drug. So we take that into account and change things. It might mean even a different medication for you. All of this to guide drug selection and dosing. And then ambulatory care. This area of pharmacy practice is the provision of integrated, accessible healthcare services by pharmacists who are accountable for addressing medication needs, developing sustained partnerships with the patient, and practicing in the context of family and community. Let me break it down. Let's say you've got hypertension. You go and see a doctor, goes, yep, you've got hypertension. Okay, so your doctor diagnoses you and then says, I'm going to turn you over to pharmacist Haimee Cho. There's a reason I'd use her name. And so pharmacist Haimee Cho is able to say, okay, we're going to monitor your symptoms. I'm going to review all of your medications to make sure I give you the right medication. You don't have conflicts. Going to monitor your response to that medication, right? Dosage. If that one's making you feel woozy, that's okay. We've got others to use. And you built that rapport with this ambulatory care pharmacist. You might call up in a couple of weeks and go, that drug you gave me, it's just making me nauseous. Come on in. I've got an appointment for you tomorrow, and works out a difference for you. Okay. And so it's the pharmacist really having this one-on-one relationship with you, working under the license of the doctor. It's part of that doctor's practice. Now, why do I say the name Haimee Cho? Because Dr. Haimee Cho is like who I like to call the fairy godmother of ambulatory care. It is the system that she created. She started in some of the countries over in Asia, then got a position here in the United States, and is part of the College of Pharmacy at the University of Michigan. How good is what she did? It is now the federal model for ambulatory care across the entire country. Come here. You can learn about ambulatory care from her. Next slide. And now this brings us to you and the Pharmacy Community College Connect, or PC3 program. And that brings me to turning it over to Madison.
All right, so what is PC3? So in short, PC3 is a program that's designed to encourage students from tribal or two-year institutions to try out pharmacy as a potential career for them later on. So that is with the long-term goal of eventually increasing the number of pharmacists who provide patient care in underserved and medically underrepresented communities. And we hope that you will continue that pharmacist education at the University of Michigan. But of course, we do not require that you come here, and you are actually open to choosing a different four-year institution. So what does PC3 actually look like logistically? So again, the purpose of PC3 is to recruit you, to support you, and mainly to prepare you for not only your current academic program, but a PharmD or pharmacist program. So it's our expectation that you will complete your current 2-year institution, transfer to a 4-year institution like the University of Michigan to complete a bachelor's degree, and at some point enroll in pharmacy school. And here we have some photos from our very first cohort of PC3 students from this past summer. Now, breaking it down, we have a somewhat timeline where we have a first or second year of your degree, of your current 2-year degree. You can be in whatever year of that you please. All we ask is that you are currently attending a 2-year or tribal institution. You are, let's say, accepted into PC3, and then that summer you join us by either commuting to our campus, or for some that may mean Zooming in, and that all depends on your partner institution. Once you have completed the summer, you will actually return to your current institution, or if you then choose, you can immediately transfer. That is a student-by-student basis. But you are always invited back for a second summer where we sort of focus in on some pre-pharmacy courses that are a little bit more intense than the first summer. And we also try to introduce you to some research. And as we continue on in your program and your time in education, we actually encourage you to also go to our Pharmacy Scholars Program, which is a pre-pharmacy boot camp that essentially just prepares you further for a PharmD program and also prepares you to apply to a PharmD program. So, in short, again, PC3 is a 5-week commuter program held from in the year 2024, actually, not 2023, May 6th to June 7th. So students will commute to campus 3 days a week and then attend virtually on another 2 days. And during this time, you will take peer-led review courses taught by current PharmD students. And all of these courses will be based on PharmD prerequisites like biology, chemistry, composition. You will also have the opportunity to job shadow current pharmacists and current University of Michigan faculty to sort of see what it is that they actually do and what the entire career is like, because as we mentioned, there are a bunch of different pathways, and so there's a lot to observe. We will also go on excursions or site visits to health centers, and we will talk more about where we actually went this summer to learn more about how people provide for underserved populations to receive healthcare and equitable healthcare at that, and also how we enact pharmacy on a more national level. You will also experience some mentoring from the current PharmD students, and they will work with you throughout the program to give you advice, tell you what it's like to be a student here, and overall just make sure that you're enjoying your time in the program. And you will also receive from them some academic advising. You'll be connected with some of our advisors here as well, and you'll get to participate in a broad range of social and academic activities throughout the time.
I just wanted to circle back. If you are in the Southeast Michigan area, you will commute here to campus. But what we have for you in the Upper Peninsula is creating the opportunity for you to commute to your home institution and then be virtual on the other days. So when we say commute, we're not talking everybody commuting here from the UP down to campus in that first year. We will support you in your communities, and we are very, very excited to be able to do that. Thanks.
So for your first year, where you will be commuting either to Ann Arbor or to the Upper Peninsula campuses, here is some of the things that we did. We listened to more than 16 speakers. I could never find an accurate count because there were simply too many. And we heard a bunch of their great stories about how they got into pharmacy, the work that they're doing, and also the impact that it's having on our communities. We also visited 3 sites. So the first one was Hope Clinic, which is in Ypsilanti, Michigan, and they serve the wider area and a large variety of needs, pharmacy just being one of them. We also went to Michigan Medicine, and the students got to go on a tour, got to see behind the scenes in a lot of different ways that the average patient does not get to see. And we also got to go to the FDA of Detroit and learn all about how they regulate medications and how they regulate what's in your local gas shop, everything along those lines. And so the students really enjoyed having these opportunities, and we're excited to provide the same or similar ones next summer. Students were also trained in HIPAA, which is the act of maintaining patient privacy, because that's pretty important. While you are touring Michigan Medicine, you're touring hospitals, you're learning a lot, you're getting really up and close and personal with these people. And we also learned the essentials of BP measurement. And even beyond all of that, we did a bunch of other stuff. We learned about University of Michigan's campus, its programs. We even networked with other incoming University of Michigan students, staff, and faculty. We connected you with mentors and advisors, again, all within the College of Pharmacy, sometimes even beyond. Students have found some great connections. And of course, students really dedicated a lot of time and energy to their own success by engaging in the program. So here are a few testimonials from some other students. We have Zoe, who said that PC3 opened their mind to pharmacy, which is really what we want from all of our students, just that they sort of come in with an open mind and see pharmacy as an option for them by the time they leave. Teddy said that PC3 is an excellent program to explore pharmacy. They got to meet a lot of wonderful people in the field, and in their shadowing experiences, they gained useful advice and guidance. They said that a highlight of their time in the program was the fun activities and the hands-on learning experiences. And Teddy made lots of memories and met so many amazing people, and said that it was one of her favorite programs to be a part of over the summer. We have Spencer, who said that they learned that a PharmD is a very flexible degree, since there are so many subcategories and branches of pharmacy, and it's really helped them to narrow down which branch they'd actually like to work in. Caleb said that PC3 is not only for people who are interested in pharmacy, but that it actually builds skills and habits that will benefit everyone, especially those seeking healthcare degrees. And also said that having the opportunity to meet and learn from professionals and professors who are part of the College of Pharmacy actually gave him an outlook on how it would feel to be a part of the college as well. So if you're still wondering why go into pharmacy, why do PC3? 2 options. Either A, you really know you want to be a pharmacist, which that's great. That's what we want to hear. Or you know that you want to work in healthcare or community care and want to see if pharmacy is the right fit for you. And as we mentioned, pharmacy has a lot of different branches. So if you're still sort of toying with the idea of going into healthcare, pharmacy is a great place to start, because as students have already mentioned, it's very flexible and you are never really tied down to one spot. And one thing we always like to remind students of is, while we do not require that you go to the University of Michigan to continue being supported by PC3, we do have for undergraduate students who meet certain qualifications, which I've detailed here, but also I encourage everyone to go check the University of Michigan Office of Financial Aid for up-to-date and fully correct information. But we have the Go Blue Guarantee, which extends to all of our campuses and branch campuses. And it essentially gives you free tuition for up to 4 years for full-time in-state undergraduate students who have a family income less than $65,000 and assets below $50,000. So to apply to PC3, we have a few eligibility requirements. The first is that you are a student currently attending a tribal or community college. And the second is that you have taken either college level Intro to Bio or college level Intro to Chemistry. And we also ask that students are at least 18 years of age by the time the program begins. So for next year, that will be May 6th of 2024. The application is not currently available. It will be available on December 1st, but that gives you an amazing amount of time to begin preparing your application. And we do have a place on our website that walks you through the information that you should have prepared and even gives you some of the short essay prompts that we will have you sort of answer and provide to us to make that application process easier. And if you have any questions about the program or this application process, please do not hesitate to reach out to us. We try to make sure that we respond to everyone in a very short time frame. We want to make sure that we are answering your questions because we want to make sure that you have all the information you need to apply and to understand what PC3 would mean for you. So you can scan this QR code or go to this link. It's also available on our website, but you will essentially get to sign up to be notified when the application does go live. Of course, you can always set your own reminders, but we will make sure to send out an email to whatever email you provide and remind you that it's available and it's ready and waiting for you. And I will just leave this up for a few more seconds in case people are still scanning. All right. So finally, I would just like to say that the University of Michigan College of Pharmacy is really committed to contributing to a diverse pharmacy workforce. And as one of the college's efforts to achieve this goal is to recruit and graduate college students from diverse backgrounds into the profession of pharmacy, PC3 is our way to do that. And so we are really putting in all of our time and energy into making sure that PC3 is a success, but also that you, the students, can engage in it and succeed as well. All right. And if you do have other questions, please feel free to shoot them over as well. But I will end by sharing our contact information in case you come up with questions after this as well. Dr. McClinton and my own information is up there. I've also included our group email for PC3 and the website for PC3. And again, if you would like to scan it, there is a handy dandy QR code there for you as well to jump on over to the website now. But with that, thank you all so much for coming. We really hope that you are interested in the program, and please do not hesitate to reach out.